Hello. Well, thanks so much for inviting us. I know Dr. Poole and I are very excited to be presenting about fetal alcohol spectrum disorder prevention and alcohol policy. Um, so, um, I'm just trying to advance the slide. Oh, there we go. So this is us. I'm Audrey McFarlane, and I'm the Executive Director of the Canada FASD Research Network. And I'd like to pay tribute to the rainy lands of Northeast Alberta, which we're so grateful for the rain because we've been under a fire watch advisory for several days now. But traditional lands of the Treaty 6, home of the Dene, the Cree, and the Métis. Nancy, do you want to introduce yourself as well?
Sure. I know many of the people. I can read down the list of folks, but I am the director of the Center of Excellence for Women's Health, which is a nonprofit research and knowledge exchange organization based and hosted by BC Women's Hospital and Health Center in Vancouver. And I'm also work with Audrey regularly because I am one of the research leads, the one on prevention for the CanFast research network. And even though the center is hosted by the hospital, I actually also live and work and play in the traditional unceded territory of the Lekwungen speaking peoples and the Songhees, the Esquimalt and Wasanich peoples, whose relationships with the land here in what we call Victoria continue to this day. So I'm excited to have a chance to present with Audrey because we seldom get a chance to present together, and really looking forward to speaking about this sort of highly stigmatized issue of FASD and its prevention and how policy plays in. So over to you, Audrey, to start us off.
Okay, that's great. And I was just thinking, Nancy, that between the two of us, we probably have about 50 years of experience on this topic. So I don't know what that says, but we've been thinking about this work for a long time. So we're going to talk, I'm going to give you a little update about fetal alcohol spectrum disorder, and we're going to talk about FASD prevention as a public health issue. Nancy's going to certainly describe the multi-level prevention model that her and her team have developed, and then how that intersection all works with alcohol policy. So just a little bit about the Canada FASD Research Network. We began in 2005 as a product of a partnership of the 4 Western provinces and the 3 Northern territories that were looking for information about FASD, some evidence that they could base their good policy decisions on, where to spend their money, what would be the most effective things. Should they focus on prevention? Should they just put their money into diagnosis? Should they really just focus on interventions? So, but they were frustrated that there wasn't a lot of evidence to help guide those decisions. So they conceived of this idea of an FASD research network, which came to fruition in 2005 under their leadership. Then in 2013, CanFASD decided that it needed to be more national in scope, and became its own not-for-profit and charity of Canada. And we have this weird membership jurisdictional partnership that helps to cover our operational costs. Our purpose is to stimulate, develop, research in FASD in areas that are going to be most meaningful for people with FASD and their families. And then to help to disseminate that information. Unlike other research networks, we don't give out tons of money to to different groups, but we do have a few key areas that we provide stimulus money, and then those groups go off and apply for other larger, more informed grants. One of our super talents, I suppose, is to bring all of the stakeholders together to help the researchers to be able to think about an area of need in a more holistic way. So bringing together those policymakers, other researchers, family members, individuals with FASD, professionals, and service providers, all to look at a particular issue. We focus in on these particular areas: prevention, intervention, diagnosis, child welfare, and justice. And then a big cornerstone of our work comes out of the National FASD database that CanFASD holds with Dr. Jocelyn Cook. And this is the only national database in the world for FASD. And so it's a really important feature of the work that we do. So why are we focusing in on FASD? Well, it's a really important issue, and it affects lots of people in Canada. So 4% of Canadians are anticipated or estimated, I suppose is the right word, to have FASD. We don't have great prevalence data around the world, not just in Canada, but 4% is a fairly accepted number, and probably an underestimation by a number of researchers. So some context for that, it's very common, 1.5 million people in Canada. And what does that really mean? In comparison to other disabilities, like autism, cerebral palsy, Down syndrome, and Tourette's, FASD is more than all of those combined in Canada and around the world. So it is a very complex disability, with prevention aspects to it. It's very stigmatized. It is very unrecognized. Not very many professionals know about it. And so people often go unsupported, which can lead for them to be involved in lots of unhealthy systems, which I'll talk about in a bit. We think about the challenges that people with FASD face in kind of two ways: those things that they were born with, those primary disabilities, and then the social things that happen because they're unrecognized and unsupported. So in the primary area, these are the areas of the brain that we tend to focus in on the most. They're part of the diagnostic assessment process. These are the areas that get evaluated because they have the most sensitivity to the prenatal alcohol exposure. And so, but everyone is unique, and everyone will have different challenges. So some people may have all of these areas impacted, and some may only have a few areas, and some may only have a few subset areas that are impacted. So it is a spectrum with wide-ranging abilities from people. We know that these folks have a lot of adverse outcomes. And when we look at ACEs, these folks score extremely high across the board. And so we know that they're having a lot of struggles. We've also come to learn that it's not just the brain that is impacted by FASD, although the most important area that we often focus in on. And we know that very few people with FASD have that, kind of signature facial features that we think about. Less than 10% have those. But what we are discovering is that many of the individuals have physical health issues. So the prenatal alcohol exposure is also impacting their physical bodies. And so things like they're much more likely to have autoimmune disorders, cancers, structural difficulties. So there's lots of things that could be going on physically with them that we need to pay attention to as well. So as I said, they are unrecognized. So Canada does not have good diagnostic capacity for people with FASD. There's about 73 clinics across Canada. They're very unevenly distributed, but many of these clinics only see like 10 or 12 people a year. So they are not like a developmental pediatric clinic that sees hundreds of patients in a year. They see relatively few people. A recent study came out by Dr. Papova that talked about the people, that 4% of folks that I said, those 1.5 million Canadians that are estimated to have FASD, 98% of them have not received the diagnosis that they need of FASD. They might be misdiagnosed or completely not diagnosed at all. So when they're not diagnosed, they're not identified, and then they're not supported, which really leads to a lack of services, a lack of research to be able to support those areas of effectiveness for them, and can lead to a lot of unhealthy situations. So we know from the research that 90% of these individuals will experience a mental health issue in their lifetime. They are 5.5 times more likely to have some suicide thoughts and actions. And then they also are much more likely to be involved in substance use to deal with some of these issues. They also are 30% more likely to be involved in homelessness or unhoused situations. We know that approximately 30% will be involved in the criminal justice system. And that number varies depending on the study that you look at. Some say as high as 60% are involved in the criminal justice system. So it seems that if we're not going to support them well in society, they are going to find a community that will support them. But it's not always the healthiest. And many of them go on to have children that they have difficulty raising when they're unsupported, which leads to quite a lot of child welfare involvement. So at CanFASD, we've been working really hard in all of these areas. On our website, we have multiple resources in all of those areas, but I just want to draw your attention to two that we've been working on quite recently. So we've released this new guide on helping to have better outcomes for folks with FASD that are attending substance use treatment programs. So we've really looked at the evidence, we've talked to the programs, we've talked to families and to individuals about their experiences. So this moving towards FASD-informed care in substance use treatment is a really great practical guide for treatment programs. And we've just updated it. I don't even have a current picture, but we've just updated it to include youth programs for youth in substance use treatment. Because we know many of them end up or get into treatment programs, but they're often asked to leave those programs quite early on. So we really want to make sure that they're having good outcomes. The other tool that we recently developed is a mental health toolkit for mental health providers to have better outcomes for individuals with FASD. We heard from a lot of families that mental health practitioners were not that were saying that they didn't have the tools to work with this population. So we now have provided from the evidence a number of tools that are available on our website as well. And I just think that we need to be thinking a little bit more about the opioid crisis and this population. There are so many intersections with being unhoused, substance use, all of mental health issues, all of these things together. We don't know exactly how many people are involved with opioid use, but we think it's a pretty high number. And so we need to be thinking about how we serve those folks in a different way in order to assist them. And I just want to remind you a little bit about some of these resources that are on the CanFASD website, to be thinking about your role in reducing stigma. So people with FASD and their families don't come with that stigma. That's something that we apply to them as professionals. So the common messaging guide was developed for you to think about how you write and talk about FASD, and so give some insight into some of those things. And then if you're participating in FASD Awareness Month in September, or developing any sort of messaging or campaigns, we have some really good resources on the website around things that are less stigmatizing for this population. And okay, doesn't want to advance. Oh, sorry, go back here. All right, so we have also been working in advocacy a bit as well, really trying to push for some national leadership around FASD. So we have a Senate bill sponsored by Senator Ravalia to bring forward a national framework for FASD. This would include looking at alcohol policy to address prevention of FASD, diagnosis and assessment, capacity, access to interventions, research, and then a number of considerations for all the stakeholders that would need to be included in all of these discussions. It's currently with the Sochi committee, and we are pushing really hard to try to get it through the Senate and then through the House before there is an election called. So we're working really hard to get that moving. And I think that's the end of me. So off to you, Nancy.
Thanks, Audrey. So I just want to talk a bit about FASD prevention in general as a public health issue before I talked about alcohol policy. And just starting with the fact that we do look into the research every year. We publish an annotated bibliography of everything written about FASD prevention that you can find on the CanFASD Research Network's website. But really a lot of attention amongst that research is still back in the area of trying to establish prevalence and trying to look at factors and influences. And you know, of course, it's really important to understand all that. These factors listed here are ones we've seen in the most recent years from doing that annual search. And you can see that there are really a range of informational influences, influences related to the social determinants of health, and some really basic structural and colonization, racism related type issues as well. So it's complex and certainly not easy to prevent. There's not going to be some magic, that the moment you realize you're pregnant, it will just be able to automatically stop. And I think, the challenges we've seen in that territory is this incredible weight of stigma, and how that plays out for both the women in terms of being able to talk about substance use with healthcare and social care providers. So it sits in the way of disclosure and help seeking on the women's side. And it sits in the way of all of the providers and people in a position to support women due to things like, lack of comfort with discussing and the need for training and non-judgmental and compassionate, empowering brief intervention and screening approaches. So the care providers have their own, work to do, as well as us creating the conditions for women to get the help they so richly deserve. We've talked a bit about that, all of that in this document that's on the Center of Excellence site called Doorways to Conversations, but really emphasizing that conversations and sharing information and promoting reflective thinking is a lot more useful for both sides of this equation than traditional screening approaches of asking about numbers of drinks a week, etc. Um, I think that stigma thing just cannot be emphasized enough. On on this slide in the center is the very excellent work by the Chief Public Health Officer talking about the levels of stigma in operation, from individual to interpersonal to institutional to society-wide. And you can really see this shining through this territory of alcohol use in pregnancy. And Lindsay Wolfson and I from the center have written quite a bit on this, both on the left-hand side from the thinking about the more institutional barriers that exist, and on the right-hand side, a really look at what in qualitative research women have identified as the kinds of stigma experienced and their wishes for how we'd manage that. But I think it's the big challenge that we have in all of it. And so that is why I really feel that we do need to use principles from the public health field overall, these ones of social justice, attention to human rights and equity, being evidence informed in the way we develop both policy and practice, and really thinking about how we address the determinants of health. And so seeing this women's alcohol use in pregnancy is really nested in a much larger challenging system with a lot of other factors bearing down on them. So I wanted to take a moment before I talk about the policy piece of it, is to really talk about how we've been thinking about what to do in Canada based on the complexity of the challenges that we face. And this is the model we've come up with to try and help us think through all the different ways in which we need to provide information and support built on supportive policy. And, clearly the informational needs, we so need to continue to have this awareness building and overall health promotion efforts being done in community as well as broadly as a nation. The work around helping us all have these conversations in pragmatic and evidence-informed ways in level 2 is super important. And of course, the work to really wrap care around women who are struggling with alcohol and other health and social issues, that level 3 work is super important. And, continuing on postpartum for support for new mothers and for child assessment and development. So, you can see these are really big areas, each one in and of themselves, and they need to be synchronized and mutually reinforcing, which is the task at hand we're all facing in the prevention movement across Canada. And I just want to honor a bit of that work that is being done. On the level one area, there's a fair bit of work in local and regional and territorial contexts to develop some health education materials. And there's two examples at the bottom there. One is done in the Yukon around Let's Meet at the Coffee Bar. And the second one done in Nunavut around a collective, responsibility for taking on this issue. So I think there's some really excellent work being done, and we can't do enough. I often hear, oh, everybody knows about that, but everybody doesn't know about it. And we need to have really great ways of conveying it. At the level two area, we continue to create resources to support providers in their role to discuss alcohol and other substance use. There's a couple examples that we've done at the center, a pre-conception book for women and their partners, and a summary sheet on the effects of alcohol, both in general and also in pregnancy, when breastfeeding, and when parenting. The level 3 and 4 work is absolutely amazing. The outreach, pregnancy outreach programs, and the work being done in treatment where it exists, not nearly enough of it, has just really is really impressive. And we conducted that should have a T in it, that word. We conducted some evaluative research to inform the level 3 work of specialized wraparound program for women. And this is a bit of an image of it. I did this work with the Nota Bene consulting group, Deb Rutman, Carol Huberstein, Marilyn Van Bibber, but really, thoughtful work with 8 programs across Canada around how they were creating wraparound care that addressed the social determinants of health and that were social justice oriented. So programs from BC, the people who are on here from BC, like Her Way Home and She Way and Max Right, are examples programs that were involved in this study, but we also involved the Mothering Project from Winnipeg, Breaking the Cycle from Toronto, and Kids First in Nova Scotia, and I'm forgetting one in Regina. Yes, there was one other service involved. We've also worked a lot in collaboration with Indigenous organizations to define what FASD prevention looks like that's community and culture led, and trying to achieve our aims to be a part of enacting the Truth and Reconciliations Committee's call to action number 33, which is about preventative programs. And about the importance of governments and others walking with communities in supporting that work. So the Mustard Seed of Hope thing here is a wonderful resource talking about the programs that are really developing culture-led programming within wraparound programs. We have actually some, guidance around Indigenous approach to FASD prevention that we did with Audrey and CanFast, and also with the Thunderbird Partnership Foundation. And this document at the bottom is a beautiful description of a number of programs that are doing FASD prevention that doesn't have that name on the door, but is definitely community and culture-led, creatively being done in communities. So lots to think about in terms of how we're taking it at the other levels other than the policy one. and really thinking about how we can really bring these 10 components into that work. Really challenging, and causing us to think creatively, intersectionally, and positively. So now I'm going to move to the policy action part. And I just realized I haven't been going slowly as promised for the French translation, and I really apologize for that. I meant to take time after each slide to give you a chance to catch up. So here I go. Lindsay and I have written this paper on supportive alcohol policy as a key element of FASD prevention. So I encourage you to read it if you want to go in more depth than I'm able to do today. But I'm just going to pull a bit from that paper to mention how we can be bringing the alcohol policy field into it. So I've put here this example of how we could be doing alcohol policy work that aligns with each of the 4 levels of prevention. And I guess I just feel that it is really important for us to be thinking, like we're trying to do on the practice level, to think on the policy level about how we can synchronize and make these policy efforts mutually reinforcing as well. And of course, before I start, I just should say that all alcohol policy is relevant to reducing alcohol use, which will have an impact on pregnancy as well. So whether it's pricing or outlet distribution intensity or whatever, that all matters in general for everyone, and including those who are planning a pregnancy or find themselves pregnant. But let's just talk specifically about the alcohol and related policies that are very much linked to this multi-level model of FASD prevention. So the first one, in the informational level and the awareness building level, I think it's really clear that, the alcohol policies related to warning labels and warning signage are really relevant here. And I'm going to talk more about that in a moment. And that at the level 2 level of discussing alcohol and related risks with all women of childbearing years and their support networks, clearly policy around having good guidance and having good training for all people who interact with women and their partners in childbearing years is really important. On the level 3 part, I think there's a lot of policy that's not strict alcohol policy as necessarily CAPE has discussed it so far, but things like service policies, including, services like the MAPS service, and how do we have supportive policy around pregnancy and alcohol in those harm reduction contexts, and also in the treatment policy context, priority treatment for pregnant women, treatment that includes mothers and children together, etc. To me, are important policies that can really affect how we prevent FASD. And of course, the child welfare policies around, criteria for removal of children are really important. Policies like birth alerts are really important. So you can see that it's just as complicated at this level of making the policies be in place and fit together as it is to do the practice level work. So I'm going to go into each one of these in a bit more depth as we go along. So we have looked in the paper that Lindsay's put in the chat a bit around, what research has been done on warning labels and signage and what works in what context, etc. And there is mixed evidence on that. But I think it's really important that we think about the warning labels and the signage, like level 1 in general, as one piece of FASD prevention, and not being expecting that it's going to solve the world's problems in and of itself, but that they can be very effective as a part of a multi-component FASD strategy. And I think it's something that we really need to be able to engage with as we're thinking about warning, signage, and labeling in general, is how do we fit the pregnancy piece in that in a way that is helpful and that is effective and not stigmatizing. Of course, a huge challenge. This blue document, I don't think it's any longer on the BC government website, but Gerald Thomas and I wrote this a few years ago, going into the research around what works in signage, warning signage to help BC municipalities. And it talked about a range of things, but including this picture from the Australian bottles. Australia has been able to get warning signage in place due to the incredible work of FAR in that alcohol policy group there, and hundreds of other organizations that were mobilized to help with that. And it was a huge battle. It's a whole story in and of itself. You may have already heard at CAPE presentations, but they were successful in getting this particular one there. Alcohol can cause lifelong harm for your baby with, 2 colors. And able to stand out against the bottle. And so, it can be done. And I think it would be a super important thing if we can pull it off as a part of a larger piece that we're thinking about. The guidance, as you well know, the guidance, Canada's guidance on alcohol and health have come out in the past year. And it does include messaging around pregnancy and breastfeeding in terms of it's safe not to use in that context. So much challenge around the messaging and how we have really tried to keep it in that territory of safety and encouragement of people not to use, and to really recognize that even at low dosages, there's a lot of effects that have been noted, but also not wanting to create the conditions for people to be traumatized by having drunk a few drinks within pregnancy. So really trying to create good guidance. The SOGC has done some great work in Canada, as have many provincial groups like the Center on BC Center on Substance Use in my province. And so I think we really do need to think about keeping that guidance current, keeping that guidance known by providers, and increasing their comfort and confidence and willingness to deliver alcohol messaging that is positive. And I'll talk a bit more about that as we go along. But it is definitely a key piece of what we need to have in place. Research on the priority treatment for pregnant women and mother-centered treatment approaches, etc., is really limited. And we really know that there's tons of research done around the problem of criminalizing substance use has been in pregnancy, which has been seen in the US, and how important it is to not go that route, and instead to build, safe care guidance, and really a lot of treatment oriented guidance and policy that can ensure women and their families get connected to the level and type of support and treatment that they need. I just put the Jean Tweed example up of the MK2 program up, just because I wanted people to recognize that, there are programs being developed that are day treatment programs that better fit the situation for mothers with children, less intensive time commitment, including interventions for the children as well as for the women around parenting and health and relapse prevention, etc. So we can do this. We can create day treatment programming and other forms of bed-based treatments as well that include moms and kids and don't mean that you have to give up custody in order to get treatment. I just want to talk a bit more about this idea of, like the Americans have done around the plans of safe care model, which is a real collaborative model between the child welfare system in the US and the substance use systems and the criminal justice system and a number of others. But I do think that we could do a heck of a lot better in collaboration policies between the substance use field and the child welfare field. And a couple of years ago now created this book around mothering and opioids, where we came up with this image of, which applies also in alcohol, around there are specific roles the substance use field can do around recovery and harms associated with substance use. There's specific work for the child welfare system that's in their lane, in their mandate, but there's a lot of work in the center, where both fields can really be thinking about supporting attachment and parenting and supporting the social and material needs of women and children, rather than saying, that's not mine, but really finding that center work defining and making sure it happens. We found in the research Lindsay and I did for that paper, lots of studies from the US, particularly around the impact of punitive policies versus supportive policies, and the challenges that you create when you don't have supportive policies, and supportive policies that are really as comprehensive as I've been talking about here. And finally, just in thinking about that policy development, I want to put the challenge out to us all as we're making alcohol policy of any kind to think about how we are integrating stigma reduction, how we are making it gender informed, health promotion oriented, and really attending to women's and fetal health, even as we're doing the broader work as well. So it really creates this opportunity for the kind of multifaceted policy um, that will, if it's linked and mutually reinforcing, will really make a difference. And just to come back to that Women and Opioids book as well, as we thought about policy and policy kind of principles, um, one of the things we felt that could be enacted in all alcohol policy and substance use policy in general is this idea of the primacy of mother-child together, and not, making that the thing that really deters women from coming forth and feeling safe to disclose their use and getting the help that they need. So we talked about these principles of inclusive engagement and asking ourselves questions like, are the policies developed with input from a wide range of women and their partners and families and communities? So that lived experience was really um, part of it. And is it kind of structurally supportive, the policy, and are in the sense of all systems and services linked, whether it's mental health, violence, housing, maternal health, income support, you name it? How are we, doing that work of collaboration at the system level that we're asking the programs to do at the community level? Are we embracing complexity? Do we have this sense of expanded risk assessment, not just how many drinks do you drink a week kind of approach to guidance? And are we, and this one is the most important one for me in some ways, are we actually optimistic that women want the best for their children, and that they can change? So, with this underlying compassion for women and valuing of women's decision making in the process. So, a major challenge for us, I think, in terms of um, how we do mother-centered alcohol policy, so that that we can contribute to FASD prevention.